All righty, let's see if we can get this show on the road. We'll get everyone out of the waiting room and here into the session with us. It always takes just a moment to get everyone here, get the cobwebs brushed off, and ready to go for our session today. So, welcome. Appreciate you taking the time to come and spend with me as we talk through practice questions and talk through all the things that can help you, especially if you don't know the answer, or if you can narrow it down to 50-50. That's my goal today, is to give you some tips and tricks to make your test experience as beneficial, as good as possible. It's a rough day. I mean, let's be honest. The NPT is a very burdensome test. So my goal today is to take some of that burden away from you, hopefully reduce some anxiety, and give you some tools to make your test experience as good as possible. So as we get started here today, if you wouldn't mind, just help me out over in the chat box. Give me a quick sound and video check. Make sure that we're broadcasting loud and clear. Those of you who are part of our VIP course, you'll be able to find today's slide deck. It's in the shared folder at the top of the live webinars page. You'll be able to easily find that. I will also share today's slide deck over in the chat box just for ease. What I'll do is I'll get a Dropbox link and paste it over in the chat box so you can see and follow along if you wish, if you like the PDF copy of today's session. All right, so today, as I mentioned, today is dedicated entirely to practice questions, how to dissect practice questions and make them, again, try to see through them as much as you can. I like to think of it as X-ray vision. You try to consider what is being tested in each question, and then identify with that clarity, you're able to more easily find the correct answer. And so that's the goal for today. As we get going here, just a couple of quick reminders about some of the things we've got going on. Our whole session today is going to be about an hour long. We'll talk through how to dissect multiple choice questions, talk about strategies you can implement on test day. If you haven't yet, be sure to check out the Npte podcast. This is a great way to go through practice questions on a regular basis. It's in small or short format so that you'll be more easily able to go through questions, especially in what I call your found time. So this is time that would otherwise not be used. So like when you're driving, let's say you're running, exercising, whatever it is, that it could be very helpful to use that found time in order to improve your NPTE knowledge and experience. Plus, just a reminder, those of you who haven't yet joined us for our VIP program, we're starting that up this week. Next week, we'll be diving into the musculoskeletal system. We'll go exclusively through musculoskeletal system questions, with the goal, again, being to identify key content areas that are difficult for students, try to talk through some things, tips and tricks to make that as less burdensome, least burdensome possible, so that your test experience is as good as it can be. So we meet typically twice a week in live sessions, plus we have a full video library. Additionally, we talk through easy ways to remember things. There's a lot of mnemonics. We'll do some examples here today, memorization tools, plus content and exam strategies. We go through all of that as a part of the VIP course. Additionally, you can schedule one-on-one phone calls with me. Great way to go through content or talk through test experience, test strategy, all of that with that full library, all of it for a 9-month access. So the VIPT program, or the VIP program, it's something you definitely don't want to miss. So let's go ahead and dive into our question strategies for today. So today, everything's dedicated to how to dissect and identify the correct answer for NPTE style questions. So the very first thing, speaking frankly about the very, very, very first thing, it's having a good or positive attitude. So really, there's nothing that will substitute for having a positive attitude as you strike off into questions. The purpose being that if you begin with the attitude that there is a correct answer and you can find it, that dramatically reduces anxiety and stress about a question as you start to ponder on which one to find the correct answer for it. And so, quite literally, you get into this self-fulfilling prophecy that can occur if you go into a question with the attitude, "Oh, this is too hard," or "I can't identify the correct answer here. There's multiple correct answers." If you do that, you find that becomes self-perpetuating. And so, my goal for you is to go the other way, meaning that you strive on each question to say to yourself, "All right, there is a correct answer, and I can find it." And so, with that in mind, that positive attitude that can lead to, again, remarkably improved performances, simply because you tend to have less anxiety, you think more clearly. And so that positive mindset really does lead to better success on test day. So it's not just a, kumbaya type moment talking about having a positive attitude, but really just walking in knowing that you are good at this and there is a correct answer, and so therefore you can find it. So as far as my method for reading the question, there are some exceptions to this. We'll talk about some of those exceptions, but generally speaking, I suggest you read a question 3 times, meaning the first time you look at it, typically you can find the general idea of the question. You get an idea that this question is asking you about autonomic dysreflexia, or this question is asking you about orthostatic hypotension, whatever it is. You can generally get a general idea. The second read through the question, again, these are very quick reads, but the second read, you're looking for key information, age, demographic data, any type of relevant history. You're looking at the summation of all of the items presented in the question. And then finally, the last very, very quick read is just seeing that you're answering the correct stem of the question with the correct answers. So think of it this way. If it says best or most or least, whatever modifier there is in that stem of the question, you'll want to be sure that you are answering the correct answer to the correct question. Because, I don't know, just by raise of hands, how many of you have answered the right answer, but to the wrong question? Super frustrating, because obviously you know the content, but you're just not navigating the test very well. And so ideally, after you've done the quick 3 read method, you should be able to then formulate in your mind, if not the actual answer, at least the characteristics of the answer, saying that, all right, I know that, like yesterday, we did a question about blood glucose. Well, even if you didn't know precisely which answer was correct, you could at least say, all right, I know blood glucose needs to not be too low nor too high. It needs to be in the target range. And so even if you didn't know 100 to 250, you'd probably be looking more closely at the mid ranges, knowing that blood glucose can neither be too high nor too low. And so in that mindset, you can formulate in your mind the characteristics of the correct answer. And then finally, you read through each option, either ruling it in or ruling it out sequentially, making sure that you have identified the most correct answer, which is, again, kind of a subjective discussion there about the most correct answer. But really, you try to find the one that has the most characteristics of correct, the one that is most relevant, the one that is, I think I mentioned this yesterday, the one that's in the proper order or proper sequence. You'll find that that leads to your best test performance. So you read the question. You should identify in your mind the characteristics of the correct answer, and then read through each option, either ruling it in or ruling it out, until you find or determine the one correct answer. So let's go ahead and do a couple of examples here together. We'll just go through this. This one is a question that comes directly from FSBPT's demo questions. They have a bunch of demos that they give as examples. So this is extremely representative of what you'll see on the test. On test day, each test, or each standalone test question, I should say, looks something like this. There is some type of scenario data. Now, this is not a true scenario question. We'll talk about those, especially next week. We'll start dissecting out musculoskeletal scenarios, neuro the next week, cardio the next week. But scenario-based questions typically, these standalone type questions usually have a scenario or a bit of information that will help you answer the question. So in this case, just reading this together, after sitting at a computer station for 2 to 3 hours, an individual reports experiencing sharp, localized pain in the left arm. When asked to show the location of the pain, the individual points to the area of the insertion of the deltoid. The pain disappears when the individual stands up and walks around briefly. Which of the following interventions is most likely to correct the problem? So that's our first reading. Our second reading, we'll look for key information. We see that after sitting for a prolonged period of time, sitting for 2 to 3 hours, they have sharp localized pain in the left arm. However, when they're asked to show the location, they point to the area of the insertion of the deltoid, so insertion of the deltoid. And finally, the pain disappears when the individual stands up and walks around briefly. So we have pain with sitting that is alleviated with standing, and the location of the pain is the insertion point of the deltoid. So what is precisely going on here? Which of the following interventions is most likely to correct the problem? So one last glance at that. Well, we're looking for interventions that are going to correct the problem. So therefore, what type of intervention would correct this type of problem? Well, we see that it's going to be a posture issue. So really, whatever can improve our posture is going to be the best or most effective intervention here. So then looking through the answer options, we see isometric strengthening of the deltoid, not particularly posture related. And honestly, we don't really see a lot of weakness here. So we're going to X out that one. Lumbar extension exercises in prone, possibly to assist with with posture. I mean, it's not terrible, but usually we consider lumbar extension in prone for some type of herniated nucleus pulposus, so it's not really a great fit. And then finally, the last incorrect answer option is instruction in shoulder active range of motion exercises. Again, active range of motion is typically a strengthening type movement. And so is there a weakness here? Possibly, but not directly. So then we're left with the final or the correct answer being instruction in correct postural alignment in sitting position. We find that that is most likely to correct the problem, instructing the patient in correct postural alignment. So again, you see that you can find the information in the question that will help lead you to the correct answer. And so in this case, instruction in correct postural alignment would in sitting position would be considered the key or the correct answer. And these other ones are all incorrect or not the best option, again, for various reasons. So just to sum up what we talked about, each question, each multiple choice question or MCQ, each multiple choice question has at least some type of information, enough information in the question to ask a question. So either a scenario or and the stem. Then you have the options with only one correct answer choice. The key is the correct answer choice. So just remember that the items are randomized. So not only for content, but each of the responses or the options are randomized. So you would not expect to get A more often than B, more often than C, more often than D. That being said, don't be too worried about patterns. So if you see like 3 A's in a row, it doesn't necessarily mean you got them all, like one of them is wrong. But that being said, you just be cautious that at the end of the test you haven't marked C on everything. That's absolutely not going to help. So don't just guess C. I'll talk a little bit about what to do if you don't know the answer. But most of the time answer options are put in pairs or some type of range, and so very often you can eliminate 2 options. We'll talk about that a little bit here in a moment. And then finally identify the one and only correct answer, or the one that is the best or most direct and effective. Again, that'll be very helpful in identifying and finding the correct answer. So let's practice this one together. So what I'll do is we'll read it together. I'll ask for your response. So you'll see a little poll box jump up in front of you about which one is the correct answer. Patient has used crutches with a partial weight-bearing toe-touch gait for the past 3 months. When progressed to full weight bearing, the patient is unable to demonstrate a heel-toe gait sequence with the involved extremity. Which of the following disorders is the most likely origin of the gait abnormality? So we've got a patient with crutches that's been partial weight bearing, toe-touch gait for 3 months. So we see that's key information. We have toe-touch gait for 3 months. When progressed to full weight bearing, they're unable to demonstrate a heel-toe sequence, meaning that they're probably striking their toe. They're not able to go heel to toe, so they're probably either going flat foot or toe heel. So which of the following disorders is the most likely origin of the gait abnormality? So we got a gait abnormality. We're trying to find what is most likely to cause this. Now, going through the answer options, we see plantar fasciitis. So as you consider plantar fasciitis, consider for a moment that the typical history or presenting factor for plantar fasciitis is pain initially in the morning, first 2 steps, plantar surface pain, especially towards the calcaneus. And none of that's mentioned here. So we don't have pain in the morning. We don't have pain near the calcaneus. We don't have a loss of range of motion necessarily. Well, I guess we kind of do, but there's not a painful loss of range of motion or painful stepping that's described here. Rather, we just see a deficit in range of motion. So a plantar fasciitis, not real great. We'll go ahead and eliminate that. Fibular or peroneal nerve palsy. Well, nerve palsy, what are the characteristics? Well, you have sensory and motor deficits. Well, we see possibly some motor here, like they can't lift up their toe very well, but we don't see any sensory deficits, and we don't see anything that would indicate any type of nerve injury. There's no mechanism here necessarily. And if you had a peroneal nerve palsy, you'd have lack of dorsiflexion and lack of eversion for the deep and superficial branches and lack of sensation on the foot, especially the dorsum of the foot. So it's not real great either. We'll skip to option D, the hammer toe. So hammer toe, what does that mean? Well, it just means that you have a flexion of the distal IP joint of the toes. Well, a hammer toe is going to be painful during toe off. It's not going to affect heel strike really at all. and chances are you just have painful toe off or difficulty with toe off. Again, not indicated here in the question, so we can eliminate that one. So we're left with the correct, what ends up being the correct answer, the heel cord tightness. Heel cord tightness, this just means that because of that prolonged positioning for 3 months in the toe touch gait, that now they're having difficulty moving the toe up into dorsiflexion. So it's very likely they'll walk with that they won't be able to go heel toe because their heel cord is just too tight, or the Achilles tendon or gastrocsoleus complex is simply too tight. So leading us to the correct answer of heel cord tightness. Excellent. So we're going to do some more practice here. I've got some more practice for you with that. I wanted to talk to you about image questions here for a minute. Just a quick note here about as you're going through the answer options, I would suggest doing kind of like what I was modeling there a moment ago, that you, in your mind, either defend or eliminate each answer option with as reasonable of a thought process as you possibly can, meaning that you need to have it ruled in or ruled out for some reason. Now, there will be ones where you just don't know the answer, so it's very difficult to rule it in or out based on something you don't know exactly. But generally speaking, you'll have at least some inclination to say that that doesn't sound right, that this thing is this is not right, but this sounds more correct. Usually there's some indicators in your mind that you can say, all right, this is starting to add up nicely to the correct answer or the incorrect answer. Now, I have had students who keep score on their answer options, meaning like in this last one, if we were to say that, say, plantar fasciitis could result from a prolonged toe touch gait, meaning that they have a lot of tightness in their heel cord and they do eventually possibly develop plantar fasciitis. You can see how you could put like one imaginary point to say, all right, yeah, plantar fasciitis, maybe it's in the running. A fibular peroneal nerve palsy would also result in lack of dorsiflexion. I mean, possibly. But the only thing that explains everything here, all of the symptoms, would be heel cord tightness. So you give, again, these are just imaginary points you're giving to each answer option, trying to identify what is the most correct one. So it's a compare and contrast game, trying to find the one that has the most correct characteristics. All right, let's talk about image or video questions. So again, I'll give you this question. So this question, this is the only time I tell people to read the question backwards. What I mean by that is don't thoroughly evaluate the image. You can look at it, but don't thoroughly evaluate it until you look at the answer options. So then it narrows your focus for what you're going for. And that's actually what I recommend for scenario questions too, or the longer patient chart scenario questions. Don't try to evaluate the whole chart until you've narrowed your focus to look what it is that they want you to find. So in this case, we do indeed see that we have a radiograph of the shoulder. Those of you who are just listening to the audio version of this, kind of difficult to visualize, but we have a radiograph of the shoulder. Which of the following conditions is best represented in this radiograph indicated by the arrow? 1, rotator cuff. 2, AC joint separation. 3, Hill-Sachs lesion. Or 4, Bankart lesion. So I'll give you a moment to respond to that before I tell you how I think about this one. All right, so we do see indeed that the image has an arrow indicating the lateral portion of the humerus or the glenohumeral joint. Now, most of the time, when you consider a rotator cuff tear is best visualized with something that visualizes soft tissue. So possibly a CAT scan, but mostly an MRI is going to be your best bet. MRI or a diagnostic ultrasound, those types of imaging techniques for soft tissue would be most ideal here. So rotator cuff tear, just not a great fit for a radiograph. AC joint separation. Where is the AC joint? Well, the acromioclavicular joint is where the clavicle meets the acromion. We see that there is joint space, but this is actually kind of a normal amount of joint space that you see in the acromioclavicular joint. Plus, the arrow is not indicating anywhere near the AC joint. So we can rule out our AC joint, rule out our rotator cuff tear. And then finally, we're left with the last two options of Hill-Sachs lesion or Bankart lesion. Now, if I were to tell you, and this is maybe the plaguey part on test day, what if you can't remember Hill-Sachs versus Bankart? Those names mean nothing to you. Well, that makes it really hard to find the correct answer. But if you know that the Bankart lesion is a labral tear, So Bankart lesions, just of note, Bankart lesions are an inferior labral tear, whereas SLAP lesions are at the top. So you have SLAP lesions at the top of the labrum, and then Bankart lesions are at the bottom of the labrum. Well, if you know that Bankart is related to labrum, we see again that would be visualized with a soft tissue type imaging technique. Plus, you would say that the arrow, which is indicating lateral humerus, is not indicating anything near the Bankart, leaving us with our correct answer, which is the Hill-Sachs lesion. So the Hill-Sachs lesion, this is identified primarily by a dent or a divot in the cortical bone, typically occurs after an anterior dislocation where the head of the humerus bounces off the rim of the glenoid as it dislocates and then relocates. So that Hill-Sachs lesion is an indication really of a traumatic dislocation. And so as far as identifying it on radiograph, you're going to look for that or see that on the lateral humerus. Now, on test day, there might be a couple of radiographs, but they are quite musculoskeletal related and they have to be very obvious, especially considering that we are not radiologists. So it has to be quite obvious. The location has to be obvious. It has to be something that is relevant to our musculoskeletal or neuromuscular pathologies. So this is an example of that. Excellent. Excellent. Most of you were able to identify that one here. Again, just a note on the poll boxes that I pop up in front of you. They are for selecting a correct answer. I actually don't see who says what, so it's totally anonymous. And I hope no one feels bad if they miss a question. Like we're all here to learn, and that should be the whole idea here, is to try to get as many of the mistakes out of your system as you can so that you have a better performance on test day. All right, let's talk through about, okay, what if you don't know the answer? Well, number one, there's no penalty for guessing, so that's great. You can put down your very, very best guess. But as far as other strategies that can help you find the correct answer, now I've received numerous emails over the years of people who are very sincere and they want to know, Will, how is it that I can answer a question correctly when I don't know the answer? And that it's kind of a tricky question because honestly, the questions are written such that it's very difficult to just guess, a straight up guess, or logically conclude without any underlying or background information. So I guess the root of the question is not how do I answer the question if I don't know the answer? The question is, how can I use the clues in the question to lead me to or to trigger in my mind what to look for the correct answer? So again, you have that baseline knowledge. Clearly, you're skilled at this. So take that baseline knowledge and now apply it to a question. That's the real key here. So as far as what I'd suggest, number one, well, I guess the very first thing is usually your gut intuition leads you to at least close to the correct answer. So go with your intuition. Again, you've been studying this for years. Chances are you remember something that maybe you couldn't articulate, but it feels familiar. So if you don't know the answer, the first thing you do is consider what your gut reaction is, but then also consider what body system is being tested, what stage of rehab. Are we talking interventions or differential diagnosis? So you're doing what you can to make decisions about this content that maybe you're not very familiar with. Little Will tips here would be to pay attention to the lengthiest answer option. So what does that mean? The lengthiest answer option, the one with the most information, or the one that appears to be the most comprehensive. Again, it's not when I write questions, I try not to make any answer appear longer than the others just because of this. But if on test day you simply don't know the answer, look at the lengthiest answer option just because it may contain more data in it that makes it more qualified. And that's, again, it's not a fail-safe, but it's just what should you do in the case you simply don't know the answer. Now, most of the time, this is, again, a little tip about that's related to test writing. It's usually very easy to write a test question with one correct answer, and then to write one or two incorrect answer options is also fairly straightforward. But the final or the fourth answer option, the third incorrect one or the fourth option total, is usually very difficult to write a plausible incorrect answer. And so very often you can eliminate an outlier when you look at the question. So again, considering that you don't know the answer to the question, look at the answer options and see if there's an outlier, something that feels unrelated, because very often there will be one of those and you can immediately eliminate it. So it usually, well, it does. It increases your odds of answering that question correctly by obviously by 25%. It takes away one of the answer options and gives you a, well, I guess, what is it? The math here. You go from a 25% chance of getting it right to a 33% chance of getting it right. And I'll take those odds. That's an important move in the right direction. So eliminating outliers. And then finally, if you can eliminate a second one, that narrows it down to 50-50. And I have so many students who can do this. Just by raise of hands, how many of you feel like this is you? I can narrow it down to 50-50, but then I have a hard time identifying the last or the correct answer. And so when it comes to that, that's honestly why and how they write the questions, is to help to force you to narrow it down to 50-50 and then make a determination or a clinical decision based on that. So here are some suggestions. Obviously, your best guess, use your gut reaction. That'll often lead you in the right direction. Another way to do it, this is what I very much recommend, is consider what would your most ideal physical therapist do in this situation, or what would a third party, like your best friend PT who you respect very much, what would they say in this particular instance? Or even take it a step farther, what would the textbook say about this particular case? So it's almost like you're hacking your own mind to say, not what would I say, what would a reasonable therapist say about this particular case? And chances are, when you're, especially on questions you're having a little bit of a hard time with, consider what, again, it's kind of a silly thing. Like let's say all of us as a class were sitting there with you on the test. Don't think, what would you say? Consider, okay, what would the class likely say in this case? Or what would the reasonable therapist say in this situation? And that third party perspective can, again, give kind of a fresh light on the questions so that you're looking at it analytically rather than second guessing or considering, what if and what if and what if. Just try to bring it in from an outsider perspective. What would they say in this? There's some agreement there in the chat box about that it's extremely common to be able to narrow it down to 50-50. And again, frankly speaking, that's how and why they write the test. They want to see what you would do, and they want to make it so that it's impossible to simply guess the answer. So, as this is a silly example, but when I was first starting PT final exam over a decade ago, I would write practice questions, and my sweet wife, who is a Hispanic linguistic major, no healthcare experience at all. She loves academia though. And so she would look at my questions that I had written, and 8 times out of 10, she would guess the correct answers. Like, well, Will, you left me a clue here and I could find the correct answer because of this. Again, with no healthcare knowledge whatsoever, she could guess the answers. And it was super frustrating because I was trying to write questions that were PT related and rather difficult for PTs. But again, she'd guess 80% of them, no problem. And so my goal then became to write questions that could not be just guessed. Like, you couldn't just look at it and say, oh, well, you could see that one. Like, Will wrote that one with, clearly an outlier here. It doesn't have any relevance to the case. So it's got to be one of these ones. So again, speaking frankly from an item writer perspective, they're trying to write it so you can't just guess it. And so what I'm trying to do is to help give you tools, at least to narrow your focus, to find the more plausible answer in the case you don't know the answer. And that, like, I wish I had a way. I mean, my goodness, if I could patent a way that you could answer the question without knowing anything about it, like, that would be the real trick, right? But unfortunately, that's unfortunately, whatever it is, the test is not written that way. And so your goal is to take all of your base knowledge that you have, which clearly you have a lot of skill in this, and be able to apply that to each question. So another thing that's critical as you consider, especially in the case where you've narrowed it down to 50-50, is consider if there is a sequential order to these answer options, meaning that one should be completed first before the next one. As an example, we as PTs should always complete our examination, both our verbal exam, a detailed history review of systems, and our physical exam. We should have that completed or understand what we're working with before then moving to our evaluation and intervention. So for instance, if you had a practice question that asked you about and I think I mentioned this yesterday, someone who had a rotator cuff repair surgery, what would you do next? Well, the first thing you do is get a good detailed history review of systems, find the prior level of function, the mechanism of injury, that type of examination data before beginning your intervention strategies, such as Codman pendulums, gripping exercises, well arm or sound arm exercises. Those are all things to consider when you are trying to find the correct answer. Is consider if there is a sequential nature to these answer questions or answer items. If you can find something sequential to them, most often you'll pick the one that you do first. And so, again, consider for a moment that you're doing things that are the safest, most effective, as well as direct. So the most direct. So whatever it is you're doing, you're choosing to do as far as interventions or examination, safest, most effective, and most direct. That's what they're going for with these questions. So again, kind of referencing back to what would you do in a 50-50 situation? What would the most reasonable therapist do? Well, what would fill that in with what would the most direct therapist do? The most direct therapist do? What would the most effective therapist do? What would the safest therapist do? And in those cases, again, it can lead you closer to the correct answer. So, and then finally, the last thing, this is what we do in the class a ton, is we try to understand and know the content. The firmer grasp you have the content, the easier the test becomes. This is what I consider to be X-ray vision on test day, where let's say you've studied autonomic dysreflexia and you understand clearly that it occurs at levels of T6 and above. You know that you have a sympathetic response below, parasympathetic above. Then it makes it easy to reason your way through a question that asks about autonomic dysreflexia. You can see through it instantly and say, oh, I know what they're testing me on. They want to know whether or not I understand autonomic dysreflexia. Or another one that I think I referenced this yesterday a little bit about the anterior interosseous nerve of the hand. So a branch of the median, it does the AOK sign, the tip-to-tip pinching between the forefinger and the thumb. And so if the AIN is disrupted, you won't be able to do the tip-to-tip pinching of the forefinger and the thumb. So again, that's an example of where you can see through the question. You can see almost immediately what it is that they're after on these test questions. And that should always be your goal, to see through it. Try to consider what it is that they are testing you on. And then with that in mind, it makes it easier to find the correct answer. All right, just finishing up here on a few things before we get into our practice questions. A few miscellaneous tips that I've talked about already, but if all else fails, put down your best guess. There is no penalty for guessing. There are some practice tests that do have a penalty for guessing. In practice, there's some standardized tests that have a penalty. This is not one of them. So regardless of whether you have, I've had people do this before. They get down to 20 or 30 questions left in the test and they have 2 minutes left. And they just start clicking answers, just randomly clicking any answer they can. They have a 25% chance of getting it right just by even clicking a random answer. So put you down your very, very best guess. The answer options are randomized. Don't worry about any patterns that show up. And so me on my end, as far as the technology I use to develop these questions, I typically write them and create them in a document. And then I shouldn't give you too much here, but I don't have a computerized randomization program. Rather, I do some self-randomization and I won't give it away too much. You'll probably, if you look at the answer options, you'll see the way that I do it. But in any case, don't worry about patterns. If you can eliminate 3 answer options, then that leaves you with the correct answer, right? So try to eliminate as many as you can. Look for opposites in the options. Again, it helps you to eliminate 50-50 so that you can get down to a 50-50 shot at answering the question correctly. And finally, just by raise of hands, how many of you have ever changed your answer from the correct answer to the incorrect one because you second guessed yourself? So don't do that. Don't change your answer. Extremely common to do. It's a terrible temptation. So don't change your answer unless you need to. Unless you actually totally misread the question, don't change your answer. All right, so with that, let's go ahead and dive into some practice questions we will do together. If you do have other questions relevant to what we've been talking about, please feel free to click those into either the chat box or the Q&A feature on Zoom. So this is a great time. What I'll do is I'll get the test question queued up here for you. And then once we get through that, through the test question, I'll give you about a minute to answer the item before then continuing on, and we'll talk about the answer together. Just some notes here. I forgot to mention these. Strategies for test taking, the actual test navigation. How many of you, if you want to share, how many of you by raise of hands are fast test takers, meaning that you complete tests very, very quickly? That's not a bad thing. Honestly, not a bad thing, simply because you tend to still have energy left at the end of the test because you did it so quickly. The trouble is, and this is just a caution to you, don't go so quickly that you're careless about the items. And I feel like this is a very obvious advice, and chances are you've done this time and time again through PT school. But what I've had people do, unfortunately, is fast test takers, they walk into the test site and they say, oh, I have 5 hours to take this test. Well, this is a pretty big deal of a test. I should take my time. And so they reinvent their test rhythm and they slow way down. And what happens is they find themselves quite fatigued, more so than normal. They have a poor performance because they tried to reinvent their test strategy on test day. So my suggestion to you is don't reinvent your rhythm. If you're a fast test taker, great. Stick with your rhythm. The only caution here is don't go so fast that you're careless. And chances are you've already done that like a million times through PT school. But just advice there, don't go so quickly that you're being careless or overlooking things. For those of you who are slow test takers, you may have to kick it in gear a little bit. You want to make sure to finish in adequate time so that you don't run out of time. You need to have obviously adequate time for each of the answer options. So my suggestion is about 1 hour per section or a half hour per half section that's the uppermost limit of your test pacing. Most likely you're going to go a little bit faster than that, but I would very much recommend that you don't run out of time. And then as far as a study strategy goes, also recommend taking practice tests every 1 to 2 weeks. So why do I say every 1 to 2 weeks? Well, it's not an infinite number of practice tests available to you, or infinite. They do cost something, especially if you're purchasing like PET exams. They do have a cost to them, so you don't have to do a million practice tests. But if you can do a test every 1 to 2 weeks, that will put you on pace to see an adequate number of questions to pass the exam. So a minimum of 4 tests. More can be better, but is not necessarily better, just because it takes so much time to dissect out a practice test that you would be better served to spend more time on one test rather than rush through it and take another test without learning from the first attempt. You want to make sure that you're just learning from every question you come across, that being the big goal. And then the final practice test you should take, it should be about a week before test day. Again, with the idea that you need to have adequate time in order to review it thoroughly. All right, let's do some practice questions. So what I'll do is I'll cue this up. You'll see a question on the slide deck in front of you. Those of you who are just listening to this, I'll read it aloud here in a moment, and we'll talk about it together. I'll give you about a minute. Ready, set, and go. Right, just a few more moments. Excellent. So this one, in a patient that is receiving prolonged systemic glucocorticoid therapy, which of the following groups of adverse effects is most likely to be observed by the therapist? So in a patient that is receiving prolonged systemic glucocorticoid therapy, which of the following groups of adverse effects is most likely to be observed by the therapist? 1, decreased bone mineral density, hyperglycemia, myopathy. 2, decreased fluid retention, hypotension, weight loss. 3, excessive sleepiness, allodynia, anhidrosis. And 4, hypoglycemia, dermal thickening, and difficulty climbing stairs? Well, if you consider that systemic glucocorticoid therapy very often leads to Cushing syndrome, you would say that the most correct answer here is that first one: decreased bone mineral density, hyperglycemia, and myopathy. These are all symptoms of Cushing syndrome, and among them include weight gain, hypertension, heart failure, osteoporosis, gastritis, dermal thinning, cognitive changes, dermal thinning, increased sweating, or hyperhidrosis. All these would be indicative of some type of corticosteroid, prolonged corticosteroid, like we're talking dexamethasone or cortisone or Z-Pak, any of the long-term or systemic corticosteroids. These other answer options all have something that's opposite. So rather than decreased fluid load, they typically have increased fluid load or fluid retention with hypertension and weight gain. So these are all opposites. Excessive sleepiness, rather than excessive sleepiness, they have insomnia, neuropathy, excessive sweating. So not anhidrosis. They rather have, what did I say? They have, well, no, did I say this wrong? They have increased sweating. They have hyperhidrosis or excessive sweating as the key here. And then hypoglycemia, dermal thickening. All these are opposites of the symptoms that you would see in the case of Cushing syndrome that is likely related to the corticosteroid, the prolonged corticosteroid use. Now, most of you were able to find the correct answer, and chances are on a list question like this, you were able to eliminate something from each of the answer options. And that's one of the things you should try to do, is to eliminate something from the answer options on these list type questions. So you can, if an answer is partially incorrect, that means it's totally incorrect. And honestly, they do love asking these list-based questions simply because you can test a lot of content very quickly with these list styles. Very, very good. Excellent. So a question comes across. I'll queue up this next one. You can read it through while I'm answering this question. A question comes across: how do your practice exams compare to other companies or to the Pete or the real exam? Are they harder or easier or the same? So as far as the PT final exams, so they are designed to be slightly harder than the actual test day. Typically our average score is somewhere around 62 to 65%. And what that means is that in order to pass the test, you have to, the closer and farther above 70% you get, the more likely it is that you'll pass on test day. It does make it so it skews slightly harder. So it'd probably be in line more with like therapy ed type questions. I believe some of the other providers are slightly easier. Regardless, the point with the exams that I created is to try to make them more difficult than your test experience for the purpose of overtraining rather than undertraining. At PT Final Exam, I've got 6 exams available to you in an exam simulator, and that's all included in the VIP course, or not every one of our courses, but we try to include that in as many courses as we can, or just for a standalone purchase. But excellent, great question, really great question. All right, I'll queue up this next one. I'll give you about a minute to respond. Ready, set, and go. All right, just a few more moments. All right, and time. So this one, the question says, when compared to upper extremity exercise test results, lower extremity exercise typically results in, that we have a lot of mix and match items here: greater heart rate response or lesser heart rate response, greater or lesser blood pressure, and increased or decreased maximal oxygen uptake. Now, I'll show you what I get to see on my end. I'll just share the statistics here. So here we go, share results. You should be able to see the proportion of students that answered each item. You'll see that there is quite a spread among all of the answer options here. what I want you to consider here, and I can almost guarantee a question on test day about upper versus lower extremity exercise test results. The reason is I want you to consider for a moment that I asked you to run a mile, just run a mile on your legs, just go running for a mile. So everyone just got back from their mile run. Now I'm going to ask you to run another mile. This time, run the mile on your hands. You can do it wheelbarrow style. You can balance on your hands, whatever you want. I think you'd agree with me that running a mile on your hands, so arguably the same workload as what you just did on your legs, is more difficult for your body systems simply because you have lesser muscle mass, you have less mechanical advantage in the upper extremities. The upper extremities also have more type 2 fast twitch muscle fibers. So that would mean that you'll have a greater or a more stressful response to the same workload. So therefore, lower extremity is going to have a lesser hemodynamic response, so lesser heart rate response and lesser blood pressure response, but an increased maximal oxygen uptake, also known as VO2. You'll see that that is the correct answer here because the lower extremity has larger muscle mass, more type 1 muscle fibers, and so it's not as stressful on the system. Upper extremity exercise will result in a greater heart rate response, a greater blood pressure response with decreased maximal oxygen uptake or a decreased VO2, simply because the muscle size, the actual muscle mass is not nearly so large as that in our lower extremities. So I can almost guarantee a question about this on test day. They're going to ask you about comparing or the normal responses to exercise for upper versus lower extremity. And this is important or pertinent for your practice because if you have a patient, let's say you throw them on the treadmill and they do the treadmill for 5 minutes, and then you throw them on the arm bike or the upper body ergometer for another 5 minutes at the same workload, you'll find that it's more stressful. You get a greater heart rate response, which would be ill-advised for someone who has let's say they have some type of cardiac event. You'd want to make sure not to overload their cardiovascular system with isolated upper extremity exercise. Very good. All right, next question here. Cue this one up. Give you about a minute on this one. I'll be quiet while you respond. Ready, set, and go. All right, just a few more moments. All right, so a patient with multiple sclerosis experiences discrete attacks of symptoms followed by periods of alleviation. Which of the following disease courses is most likely present? So a little bit of I guess, kind of a level 1, maybe level 2 question here about you've got MS and you're trying to describe a discrete attack of symptoms followed by periods of alleviation. So therefore, which of the following disease courses is most likely present? Well, the correct answer here is option 4. So of the answer options, we've got clinically isolated syndrome, primary progressive, secondary progressive, or relapsing remitting disease. And this is the description of relapsing remitting disease. It's the most common course of MS, and it is described as discrete attacks of symptoms followed by periods of alleviation. That is the description. That's the definition of relapsing remitting disease. Now, very often, relapsing remitting will convert eventually into a secondary progressive. Secondary progressive MS is where you have the relapsing remitting, but with each relapse, you have irreversible worsening. So it's a ratcheting effect that's getting worse and worse and worse over time. So very often you start with clinically isolated syndrome. That's the first episode. You don't know what it's going to present like after the first episode. Then very often the most common case is you go into relapsing remitting disease. So clinically isolated syndrome, then relapsing remitting disease, and finally converts into secondary progressive as the course of MS progresses. Primary progressive, that's just where it's a nearly continuous worsening, and it does happen And there are some patients with that, but it's not the most common presentation of MS. All right, let's do a scenario-based item here, and then we'll see how much time we have after this scenario-based item. So again, audio only, it's going to be a little bit difficult to go through this scenario. I'll try to describe it as best I can. I'll give you about a minute. There's 2 questions related to this scenario. I'll be quiet and give you about a minute on each one and then advance the slide, and then we'll talk about it together. So I'll give you about a minute, maybe a little over, just so you can read the scenario. Ready, set, and go. All right, just a few more moments on this one. All right, now we're going to advance to the next question. So you'll see the poll box jump up in front of you again for the next question. The same scenario. Next question. Ready, set, and go. All right, just another moment. Okay, so this scenario, obviously talking about a 65-year-old male with a recent fall, Parkinson's disease, depression. We have some medications listed, including carbidopa, levodopa, a timed up and go data, so 29 seconds with end block turning, Berg-Bounds test, freezing of gait. We have a lot of data for this patient. Now we have to answer these 2 questions, and this is, I feel like, fairly representative of what you'd see on test day. There's more data in the chart than what you'll answer the questions with, and that is meant to represent what your PT practice is like. You'll often see patients with a very detailed chart, and you'll be making decisions about parts of it, or the most pertinent parts that are relevant to the discussion at hand. And that's what's being represented by these questions. So first question says, which of the following measures is the most appropriate target aerobic exercise intensity? Well, if I were to tell you that heart rate is a poor measure on folks with Parkinson's disease, that's because of the depressive effects in the substantia nigra, where they have really all well, they get bradycardia, but they get bradykinesia. They're not able to move very well. They have a decrease in amplitude of everything. So the autonomic dysfunction leads to a decrease in heart rate. And so that blunted heart rate response or blunted cardiovascular response means you can't trust heart rate to be an indicator of your aerobic exercise intensity. So therefore, you're left with, what else would you do? Well, you'll use a rating of perceived exertion, or an RPE measurement. And the target here should be something in, like what they say in big and loud therapy. So big and loud therapy, you're trying to move in large amplitude, whole body movements. The largest and fastest you can move, it will be perceived by the patient to be quite exertional. but that's what you want to push towards in order to actually get any change in the patient. That because of the autonomic dysfunction, they will respond, they'll have a relatively lower heart rate than normal. So you can't trust the heart rate. So you have to push them to their largest and largest amplitude movement possible in order to actually get some aerobic exercise that is effective for this patient. So you want to trust the RPE, especially at the higher levels. So it'd be between what is it? Usually about 8 out of 10 or 17 to in the 17 range on the 6 to 20 scale. So the second question about this one was a little bit more straightforward. It's asking about if the patient takes all of his prescribed meds at one point in the afternoon, when would you prescribe or schedule therapy? Physical therapy should be scheduled during which of the following time periods? Well, the ideal time period is 30 to 60 minutes after the dosage is received, because Sinemet or levodopa, the single most effective drug for Parkinson's disease, has its peak effectiveness somewhere between 20 60 minutes after dosing. So as a result, you'd want to target or schedule your therapy or your exercise to be performed 20 to 60 minutes post administration of levodopa. So it's a timing thing. As PTs, we do this all the time, especially related to pain medication. I do this all the time, where someone who's had a total knee replacement, you'll schedule their therapy about 30 minutes you'll tell them to schedule their pain medication dosage 30 minutes before therapy, so that it's at peak effectiveness during your therapeutic intervention. And you'll find that that's when you'll be able to get the best effect. Now, the exception here would be the case of insulin. Insulin reaches peak effect about 30 to 60 minutes after, but you'd want to avoid exercise during that period, because you could have hypoglycemia occur if you exercise plus have insulin on board. That'll result in hypoglycemia, and the patient could pass out on you. So that's just an example of timing your exercise with medications. A little bit of a dual purpose question. They're asking you about meds, but they're also asking you about therapeutic intervention. So that's just an example. All right. So as we come, let's see. Oh, yeah, we're about here to the hour mark. This is a great time. Well, I'll queue up one more question here to talk about, and then we will conclude for the day. Let me go ahead and I'll queue up this next one. It's a picture or image question. I'll be quiet while you respond. This will be our last question. And this is a great time. If you have questions for me, go ahead and queue those up in the Q&A box. So I'll give you about a minute on this one. I'll be quiet while you respond. Ready, set, and go. All right, just a few more moments. All right, so this is one of those annoying questions that you have to visualize what's going on in order to then then find the correct answer. So a bit of a visualization that has to occur. So for which of the following activities will the mobilization indicated in the photograph be most effective? So we'll glance at the photograph and we see this is an anterior mobilization. Anterior mobilization, just as a little mental practice here, anterior mobilizations are best used for what type of arthrokinematic movement? So according to the roll and glide rules, if you want to roll posteriorly into plantar flexion, you would do an anterior glide. So we see in this question, or see in this picture, an anterior glide of the talocrural joint, which is going to be most beneficial for plantar flexion. So for which of the following activities will the mobilization be indicated in the photograph be most effective? Descending stairs, heel raising, lifting foot on a small step, or walking up ramp. So descending stairs, this requires quite a bit of dorsiflexion as you consider as a person. Let's see if I can draw this. As a person is going down a set of stairs, they require significant amounts of dorsiflexion on the trailing foot as they're going down the stairs. So that the descending stairs is not a good fit for requiring plantar flexion. Heel raising, so heel raising, that means raising up onto your toes. This does require plantar flexion, so we'll just mark that down that plantar flexion is required here. Lifting a foot onto a small step. So as you consider a person who's lifting the foot up onto a step, this is going to require some type of at least neutral dorsiflexion, if not a little 10 degrees of dorsiflexion. So dorsiflexion is required here. And then finally, walking up a ramp. You could make an argument, okay, they do have to plantar flex during the gait cycle, but you have to plantar flex during every gait cycle. Rather, to go up the ramp, as you're trying to walk up the ramp, you have to have excessive dorsiflexion in order to travel up the ramp. In fact, that's why runners very often get shin splints or tibialis anterior tendonitis, because they're running up the ramp and they're getting excessive movement or excessive activation of the tibialis anterior. So again, requiring dorsiflexion. So that leads us to our correct answer, which is heel raising. Heel raising is the only one that is relevant to plantar flexion, or directly relevant, I should say, to plantar flexion, where these other ones are not quite so. Like I said, the second most correct answer would probably be walking up a ramp. But again, it's not direct as much as heel raising is clearly the most direct and relevant to plantar flexion. Good. And most of you, just if you want to see how everyone responded to that, most of you were able to narrow it down to those two options, either heel raising or walking up a ramp. And chances are you were probably thinking about the plantar flexion to go up the ramp, but plantar flexion is required for all gait cycles. But the one that clearly requires it is heel raising, going up on your tiptoes. All right. So with that, let's go ahead and we'll come to a conclusion here. What questions do you have for me as we come to a conclusion here today? Wallace asks a question. So if the previous question asked, what is the best time to schedule a patient taking insulin? What would be the best answer? So for insulin, you would avoid exercise during that 30 to 60-minute window after administration. So really, you do exercise before administration, or you do exercise 2 hours post-administration, just so you're not in that double time or that peak effectiveness time for insulin. So the correct answer would probably be 2 hours. If you do insulin administration, exercise 2 hours post. Excellent. Question comes across, how do you get a coupon code for any of our classes? The easiest and best way is to get a group of your cohort together. So 5 or more is the best way to get a coupon. So we do have group discounts as always. So if you want to, if you're involved with your class president, you want to get 5 or more of your cohort together, we can give you some sweet deals. As far as the recording of today's session, I will post a version of it on our YouTube channel. So you can find that at youtube.com/PT Final Exam. Find PT Final Exam on YouTube. I'll also post an audio version of this on our podcast if you'd like. You can find that on the Npte podcast by PT Final Exam. Plus, be sure to follow us on all the socials. So Instagram, especially, we're putting a lot of content out lately. Instagram, Facebook, everywhere that you're looking for stuff, we've got it there for you. Cool. Other questions as we come to a conclusion here today? Just while you're coming up to your last questions, just want to say thank you. Thank you for taking the time to come and spend with me. I know that this is a stressful time, stressful period for you. Thank you for what you do. Let's be honest. What you're doing is a noble and good thing, not just for you, but for your family, for your patients. There's so many good things about what you're doing, and it's totally worth doing. So thank you. Thank you. Thank you. Thank you for your efforts. Okay, with that, we'll bring it to a conclusion for today. I'll see you all next week in our musculoskeletal series. We'll begin. We'll go through musculoskeletal content and questions. Again, very much appreciate you. I'll catch you all next week. Have a fabulous day, everyone. In the meantime, keep a grin on your chin. Will Crane fist pumps all around, and take care. Have a great day. Talk to you soon.